tip for you guys. You'll see for you guys. You'll see. Okay, hello everyone. Welcome to our 56th webinar. It's nice to gather again. As all of you may know, I'm Dr. Park, the director of WEBCEPH X. Before we start the webinar, please take note of this. Thankfully, with the WEBCEPH X webinar series was able to happen or because of our speakers who shared their knowledge with us for free. All the rights related to the webinar belongs to our speakers. Thank you. Today we have invited Dr. Cazenave, and she will give a lecture regarding control of the mandibular incisor, a vital asset for class 2 malocclusion correction. She is a doctor in dental surgery, specialized in orthodontics and Dento-Facial Orthopedics, a former assistant professor at the Faculty of Bordeaux II, teaching assistant at the University of Lorraine and Bordeaux, full member of European College of Orthodontics, speaker for American Orthodontics France, and private practice in Brive la Gaillarde, lingual and buccal orthodontics for adults and children. Okay, hello, Professor, Doctor, are you there? Okay, can you hear me?
Yeah, hello everyone. Thanks,
Hello,
Dr.
nice to meet you
Park.
again.
Yeah, thanks for your kind invitation and introduction.
And thank you for allowing your precious time to share a lecture with us today. We have already 26 members attended today's webinar through Zoom. I think many of them are attend the webinar through the YouTube channel. Okay, and I'd like to introduce today's panel, Dr. Ye-Hyun Kim and Seok-Ki Chung and Min-Seok Jang from South Korea.
Hello, doctor. It's nice to meet you.
Hello.
Thank you for
nice to meet
having
you.
this great webinar. Thank you.
Okay, thank you for coming. Thankfully, with the permission of our speakers, this lecture will be streamed in YouTube. If you have any questions, kindly send me a private message through the chat box of Zoom or chat box of YouTube channel, and then Dr. Caroline will answer them after the lecture for 15 minutes, question and answer time after the lecture. Okay, are you ready, doctor?
Yeah. Let's go.
Okay, let's go. Okay, have a great time through this lecture. You can share your screen. You may start now. Okay.
Okay.
I can see
it's
your
a great
screen.
pleasure. Can you hear me? Everything is okay?
Yes. Everything is okay. Screen? Go ahead. I turn off my video and mic.
No, it's not the. I haven't shared the good one, I think.
Move to the next page.
No, I think it's not the. The good screen. I don't know how to change it.
You'd better turn off the share screen button and try it again.
Okay.
Take it easy.
And now I will try it again. Oh, sorry. I don't know why. Good.
Yeah, this is not the full screen. With your script.
I don't know why, but no, so we can start.
No problem. Yeah, no problem. We all know you are friends, so it is okay to show us the script.
Yes.
Script. Yeah.
Okay.
Go ahead.
It's a great pleasure to share my knowledge with the WEBCEPH community. My topic today is a very classic subject, the control of the inferiors and incisors in class 2 corrections, but I would like to enlighten it by the use of our modern tools, I mean TADs. I would like to start with a short presentation. My office is in a small town of the middle of France, open since 2010. It's a beautiful area, near two very rich departments for their landscapes and their culinary specialties. Brive was a breadbasket for France during war. Here is my office and staff, along with my associate, Dr. Bayer, on my staff. We are Virginie, Tatiana, and Vanessa. So it's a small office, but a very good working environment. In France and more widely in Europe, we have 60% of patients who are in class 2. Having control of the mandibular incisors is one of the main goals of our treatment. In association with vertical molar control, it determines the quality of skeletal response of our class 2 treatment. It also takes part in the control of the occlusal plane, and it's essential for the preservation of the periodontium in the frontal area. Therefore, mandibular and incisor control represent the key to our functional, aesthetic, and periodontal goals, as well as determining stability. The use of TADs enables us to achieve these goals in a context of treatment without premolar extraction. Through key decision criteria for rational mechanics, we will see how to optimize our class 2 treatment by contouring the mandibular and incisor. 2 years ago, I have received and transferred this patient. We don't know what happened, but what is sure is the incisor should not be centered in the mandibular symphysis at the end of the treatment. Thinking of the inclination of the tooth, we could find good cephalometric position, but it's out. To my mind, it is not a simple question of prescription, but a biomechanic failure. So even if we have a slight crowding, alignment always promote the centering of the incisors because they are going towards low resistance areas. It follows a transversal expansion, well supported with Copernicus wires and much more critical sagittal expansion. And class 2 biomechanics will accentuate the incisors' decentric position. This patient has been treated without skeletal anchorage. His parents preferred that we didn't use mini screws. He has a full class 2 treated by a class 2 activator, followed by braces and protractor. So here is the outcome with a class 1 finishing, but a gummy smile, and a projection of the lower lip. In fact, we can observe the clockwise tilt of the occlusal plane and the labial version of the incisors, both consequences of the class 2 mechanics. So what are the key to enhance aesthetics in class 2 malocclusion correction? We have to promote the best maxilla position to expose the smile and enhance the mandibular growth. Thus, we have to determine which place for the maxillary distalization. If we make the choice of alveolar decompensation, we will be able to promote the mandibular response and get a better integration of the chin and the profile. We will reduce the need for maxillary retraction and better the sagittal position of the maxillary incisors with less torque to reach the class 1. Contrarily, mandibular sagittal expansion reduces the mandibular response possibilities and increase the need for anterior torque to achieve class 1. So what do we have to control and focus on in class 2 correction? Our decision-making criteria are always founded on clinical and cephalometric analysis to determine the class 2 origin and typology. If we make the choice of alveolar decompensation, do we need transversal expansion? And it's not only a question of maxillar transverse deficiency, but it's also depending on your repositioning goals, because the more you have to distalize the lower molars towards the posterior alveolar area and the angles, and the more you increase the intermolar width. So you might anticipate to avoid the operation of a crossbite. Could we get incisor repositioning by class 3 elastic stretch from maxillary mini screws or by arch retraction with mandibular mini screws? concerning the vertical control, we need to assess the alveolar height anteriorly and posteriorly to determine the occlusal plane orientation and equilibrate the end-load schema. Therefore, we have to assess the position of the stomion and how the smile is exposed. Our main goal is to optimize growth by helping counterclockwise rotation and also getting good maxillary positioning to expose the smile. Finally, we need to protract the mandible, and in this case, we have to control the side effects of our biomechanics. To my mind, whatever the chosen mechanic, the incisor centering need to be anticipated and the occlusal plane observed. We all know that there is an interaction between three main goals: the mandibular incisor centering, the occlusal plane control, and the maxillary incisor exposition. That has been developed a lot in Asia with two main goals, I think. The posterior vertical control and the molar distalization to easily treat patients with class 3 malocclusion, hyperdivergency, and eye discrepancy. Then they have been used for the control of traditional mechanics, and regarding to their specificities, we need to optimize their use in hyperdivergent patients. Our own masters had a good understanding on all the facial growth process. Crickmore said something like that: if we were able to control molars, we could treat roughly all the malocclusions. With that, the vertical control of molars is always present unless mechanic schemas with high anterior hooks or vertical bands in the wire to compensate. This fact induces a choice to do for maxillary or mandibular anchorage. In the past, I was often anchoring the maxilla by mini screws with headgear effect exacerbated and consequently a smile line often too much lifted. And you can see that fact on the second picture. So all these patients have been treated with maxillary anchorage. As the smile line has been lifted, the smiles look aged, and we need to stop that. The more we move back the maxillary arch, the more we decrease the posterior maxillary alveolar height, so the more the smiles goes up. And we know that the occlusal plane in mesodivergent patients should be tangent to the occiput and the stomion positioned 2 or 3 millimeters from the edge of the maxillary incisor. Here, a very interesting article published in the AGODO. All the situations have been evaluated, and we can understand that the direction of the anterior traction determines the incisors' behavior as well as their vertical control. On these X-rays, we can see the effect of a mandibular retraction with mini screws on the incisors and on the ingression of the molars. As we have obtained a counterclockwise rotation of the mandible, the lips are now relaxed. The inferior incisor control as well as the posterior intrusion allowed the vertical closure of the compass. When you want a counterclockwise response of the mandible, you need to be aware of the molar's antagonist extrusion in monomaxillary anchorage patterns. If the muscles can counteract this extrusion, you should anchor it twice, on the lower and on the upper arch. In class 2 correction, you must adapt your mechanic to the vertical typology, to the situation of the maxillary incisor, anterior posteriorly from the frontal plane of Sassoon and vertically to the stomion. We adapt the centering of the incisor, of the inferior incisor, we see where the apex is, and we make the choice to make a translation or a version. To change the behavior of the incisor, you can change the length and the position of the anterior hook. And we have a choice to do between upper mini screws and class 3 elastics, or lower mini screws and mandibular protection or class 2 elastics. So we will see now when we could use maxillary mini screws, expecting a headgear effect. Here is Alicia. She has been treated by a two-step treatment. She was 10 at the beginning of the treatment, and she has the skeletal class 2 and was mesotrend with an hypodivergent tendency. On the intraoral view, we can see she has a maxillary transversal deficit and a class 2 molar relationship with supraocclusion. The X-rays shows skeletal class 2 by mandibular retinosclerosis. She has meso with a brachy tendency. She has a protrusion of both incisors and a supraocclusion. She has been treated with a class 2 activator, and we see her again in a permanent dentition. So now she has a class 2 subdivision, not only due to the rotation of the 35, but also because of deviation of the mandibular midline with an interincisal maxillary point nearly centered. Her face, and you can see her chin with a small symmetry. And this smile is nicely positioned, and we know we don't have to move the smile line nor the maxillary incisors. So here are my guidelines that help seeing the posterior alveolar height, SNA, SNB, AMPA, and the maxillary incisor inclination to the palate and to SNA, but also to the frontal anterior plane of Sassoon. This plane is perpendicular to Frankfurt and joins the cutaneous glabella point. Before, I was using the analysis of Steiner and Tweed, but the skeletal anchorage specificities require adaptations. So it's a mixed analysis, finally similar to an architectural analysis. So we have to control the mandibular alignment with class 3 elastics and cordon the maxillary screws. Here the advancement of the treatment. Then a mandibular protector with an asymmetrical activation is needed. Here I put the American Orthodontics boroscope in place for 6 months. The asymmetrical reactivation is realized by crimpable shims on the class 2 side, so it's a gradual activation. You can see here, yeah. We can then compare the different X-rays at T0, T1 before mandibular protection and T2 after protection. The control of the incisors is good, and we have also a good equilibrium of the in-law schema. What can we see on this superimposition? We have superimposed the palate with a posterior registration on the pterygoid apophysis and stable osseous landmarks. So it's a best fit registration. There's no strain on the maxillary growth, and the alveolar bone age are respected without descent. And we have a good mandible response. You can see. In these slides, you can see the respect of the mandibular incisors positioning and the contact device response of the mandible made noticeable by the difference of the edge of the lower part of the symphysis. So we have a contactile rotations. Here is the outcome at the end of the treatment with a class 1 relationship. We have a good exposition of the smile and the midlines are well centered. Here, our face at the end of the treatment and a smile with a good centering of the midlines. And the chin now is perfectly centered. Let's see now the case of Camille. She was 12 at the beginning of the treatment, and she has a well-positioned smile and a slight misalignment of the maxillary midline. In the antral views, there's a unilateral class 2 on the left side, and the misalignment of midline is very slight. The class 2 is due to an asymmetry of both maxillar and mandibular arch, and due to an occlusal tilt, occlusal plane tilt, which brings the mandible to a distal position. And it's often the case in class 2 subdivision. The X-rays show a skeletal class 1 associated with a mandibular asymmetry and a mandibular proconation. The maxillary incisor is slightly advanced to the frontal plane of Sassoon. So what are the levers of this case? The mandibular arch asymmetry is not so important, and the tilt of the mandible is due to the tilt of the maxillary occlusal plane. So the yaw is a functional consequence. The specification, to summarize, we have a class 2 by maxillary asymmetry, predominant to the mandibular arch asymmetry, a slight tilt of the maxillary occlusal plane, a misalignment of the maxillary midline, and no mandibular crowding. So our treatment planning will be upper alignment, maxillary mini-screws insertion between 5 and 6, mandibular bonding, leveling with class 3 elastics, control with 2.5 ounces followed by 4.5 ounces stretched from mini screws. Distalization of sector 2 with a coil of 150 grams and 5 millimeter length. Asymmetric elastics, it's for class 2 maxillomandibular resolution. On these intraoral views, we can see the mechanics with a vertical connection between the wire and the screw, which with an elastometric strain on the right side and a rigid connection on the left side to control the tilt correction. The left class 2 is corrected by the action of the class 2 elastic and the unilateral maxillary retraction. So here is the outcome after debonding with a good class 1 relationship, a good centering of the midlines, and our face, and a smile with a good exposition and symmetry. We can see on the X-rays our outcome with a good control of the mandibular incisor, which is less proclined, and a perfect position of the maxillary incisor tangent to the frontal plane of Sassoon. Here's the superimposition. They show an harmonious growth of the face with contact-localized rotation. No stripping is needed here for the incisor repositioning. It's only biomechanics. After 2 years retention, she has always a well-balanced occlusion in a class 1 relationship. A good centering. And the lateralities are equilibrated on. She has a unilateral alternated mastication. And these functional outcomes are a key for stability. After 2 years, her smile is nice and well exposed, and she has still the mandibular splint. Here's the last X-rays and superimpositions with a low vertical growth pattern and counterclockwise rotations, both maxillar and mandibular. The superimposition of the condyles show a good respect of the alveolar crest and the cortical bone. No descent here. Our maxillofacial growth is continuing with a slight counterclockwise rotation. So this is an harmonious development. Another case, we have Emily. She was 13 years old at beginning and has a class 2 with crowding. As we can see, she has an asymmetrical class 2 with a maxillary deviation of the midline and an ectopic canine. There's no possibility for expansion in her case. The X-rays revealed a posterior maxillary deficit and hypodivergent tendency. She has a skeletal class 1 and biproconation of the incisors. The maxillary incisor is well positioned to the reference line of Sassoni. The angulation of the teeth in the sector 2 was favorable to a spontaneous correction of the class 2 molar relationship during alignment steps. And at the beginning, our compliance for the elastics wearing was very bad. Then she understands she needs to help me. She also starts lingual re-education. These two conditions need to be fulfilled to increase the overbite by plans closure. So here are the occlusal outcomes with a good class 1 molar relationship. It is a phase at the beginning, and we can see now the evolution of a smile with a nice exposition at the end of the treatment. However, there is still a proconation in this case. The soft tissues are well positioned and the upper incisor is placed on the frontal plane of Sassoni. Now we have to discuss about the use of mandibular mini-screws. We have to recognize two different situations of class 2 malocclusions. In the first one, the specificities are patient hypodivergent, slight maxillary proconation, the stomion is okay. We have a posterior maxillary growth deficit, a mandibulary proconation, or crowding. In this case, we need to make the choice to put the mini screws in the mandibular arch, and we use class 2 elastics or mandibular protection according to the mandibular rectonatism importance. So you have understood that in this case, we will not put the screw in the maxilla, but instead we will utilize a mandibular schema to allow for maxillary growth with counterclockwise rotation. The occlusal plane has an anterior rotation center in this schema. So we also have a mandible anterior growth, and we know that is the best way to have a class 1 in hypodivergent patients. We can find this fact in the study of growth by Lorraine and Gasson. The extrusion of the maxillary molar is well compensated by the condylar growth, which is stimulated by the temporomandibular joint decompression. It's different in high vertical growth patterns and hypodivergent patterns. When the specificities are high alveolar posterior height with maxillary proconation and high stomion with a gummy smile, you should insert the mini screws in the upper arch. But if there is also mandibular crowding, a mandibular proconation, and if we need to protect over 3 millimeters, we also should anchor the mandible. In this situation, we want to promote mandibular counterclavius rotation, and we have the possibility to combine maxillary retraction and mandibulary protection. Depending on the strength of the elevator muscles, we could choose a first option with maxillary mini screws between 5 and 6, or in case of low strength, typically in high alveolar posterior height, we could choose a 4-screw schema to avoid the compensating molar extrusion. The goal is to obtain a counterclavius rotation of the mandible by reducing the alveolar posterior height. The less favorable the growth is, the more it requires a posterior vertical control, but also interior. It's a question of mechanical closure versus condylar growth. The center of rotation is posterior to close the compass. Shorter is the anterior hook and higher is the vertical component. As a consequence, the occlusal plane is lifted. Let's see some case. As shown, Valentin has a class 2 with crowding in a class 1 skeletal pattern. The intraoral photographs show an occlusal class 2 with crowding. The class 2 is not complete, but about 4 millimeters. So we aim to distalize the molar for crowding correction. On the X-rays, we can see he has a skeletal class 1 and he has maxillar discrepancy. We have made the choice to use maxillary mini screws to distalize the molar just for alignment needs. At this time, I didn't focus my attention on the occlusal plane orientation, so I didn't see the vertical deficit in the maxillary posterior area. And the particularity of this case was that it was very easy at each appointment because we just had to check to see if everything was okay. At the time, I had forgotten that I aimed to distalize only for alignment needs. So we continued to distalize the upper arch, and the next slide will show what goes wrong with this case. At the end of the treatment, he has an occlusal class 1. We have bonded mandibular splint, and he has a maxillary plastic retainer for night. As we have retracted more than our initial goals, we can finally observe that the smile has gone up a little. On the profile, we can see that he has proconation of the lower lip, and we will see why on the X-rays. More than this, the X-rays show proconation of both incisors, as well as the lower lip. We should have removed the maxillary screws, put them in the lower arch, and retract the arch for 4 months in association with class 2 elastics to keep the occlusal class 1. As can be seen in the growth pattern, the maxillary vertical anchorage is too strong. We would get better results with mandibular anchorage in regards to the occlusal plane orientation, the posterior alveolar height equilibrium, and to the incisors inclination. So to summarize, with the cephalometric analysis, there's a residual biproconation, the decrease of Fessine, and the height inclination of the upper incisor towards the frontal plane of Sassoon. The maxillary vertical control is too high. We need to know when anchorage burn becomes a necessity. Here, the maxillary retraction is too important. The solutions are simple. Move the screw to the lower arch as soon as the curling is resolved and obtain a correction of the residual mandibular pronation. After that, finish the occlusal class 1 using class 2 elastics. This is Valentine's Bordeaux. His smile is not really poor, but we know that we should try to avoid its retraction. He presents an asymmetric occlusal class 2 with maxillary curling. The X-rays are showing a skeletal class 2 by mandibular rectonatism, which is compensated by a mandibular proconation. Disappointed by the default of smile exposition of his brother and the excess of lower lip proconation, I have chosen another biomechanic option with lower meniscus. We are also presented with a case of low vertical posterior growth. In this growth pattern, we must induce counterclockwise rotation of both maxilla and mandible. The occlusal pain center of rotation will be anterior, allowing the exposition of the maxillary teeth. The mandibular screws have been used to control the alignment and centering of the incisors. On the maxillary arch, 2 anterior bite blocks have been bonded to enhance growth and facilitate the overbite correction. Class 2 elastics are applied night and day 2.5 ounces to 4.5 ounces. And now a smile has a good exposition. If we compare the X-rays, we can observe a decrease of the lower proconation. The arch has been retracted without wisdom teeth extraction, and there is no stripping of the anteriors. As a result, we have obtained the class 2 correction without reverse effect and a good projection of the maxillary incisor tangentially at the anterior Cazenave plane. The cephalometric analysis showed that there is no back movement of the A point. The maxillary incisor crown is tangentially oriented to the anterior plane of Cazenave, and this fact can show a good exposition of the smile. Leo is another patient with a large smile and a good exposition of the maxillary teeth. The profile photographs show that he is also in class 2. These intraoral views are the re-evaluation status and show class 2 on the situation after expansion. This stage was needed by transversal compensations and retained cuspid ricks. On the X-rays, we noticed that we have the same lack of maxillary vertical growth. The alveolar posterior height is decreased compared to the mandibular alveolar posterior height. You can see it there. We have a mandibular proconation, but there is no maxillary compensation. There is also an increase of the overbite. So now we have to make our choice. First situation, we have lack of maxillary posterior alveolar growth. He has a low angle growth pattern with upper and lower proconation. So we will opt to use the mandibular meniscus. We could enable the posterior maxillary growth by the association of inferior meniscus schema and bonding of anterior bite blocks. The bite blocks will help to level the curve of space and to allow showing in class 1 relationship. At first, we use mesial cuspid hooks, and then we use mesial cuspid hooks for lingual version of the inferior incisors. And then we distalize the traction point to continue with bodily movement. We can see on the X-rays the importance of the inferior incisors recentering without any stripping or extraction. The wisdom teeth are still there, and they participate in the distal growth of the arch. Moreover, the maxillary incisor is perfectly positioned to the entire frontal plane of Sassoon. The incisor recentering and the retraction is fully compensated by the posterior growth of the arch. Finally, we just need light recentering of the incisors and a good reflection on the occlusal plane to optimize the growth rotations. We use the existing levels. In this case, the MPA has decreased about 8 degrees. A smile during treatment, and here are the outcomes at debonding. And a smile is always laughing, and it's quite difficult to get a good picture of a smile. Now, let's turn to biomechanics reflection with the consequence of the entire hook's position, the necessity of extraction for inferior incisor recentering. When we talk about centering rather than repositioning, we take for reference the symphysis. I mean the all the bone. So 3 situations can be encountered. In the first situation, the apex is well positioned at the center of the symphysis. The defining issue will be how long do we need to apply class 2 biomechanics? In situation 2, we need to avoid any labial movement of the tooth. There is a labial risk of dehiscence. So we need to retract with bodily movement. We should choose a schema with mandibular meniscus and a distal cuspid hook with 6 millimeter length. In situation 3, the tooth is proclined with a distal position of the apex into the symphysis. We want a lingual version and have 2 possibilities depending on the vertical control of the incisor expected. With the class 2 elastics on upper meniscus, there is an extrusive component, which is useful in open bite cases, contrarily in deep bites, and when the stomion is low. A schema with mandibular meniscus and short mesial cuspid hooks is the best choice. In each case, pay attention to the height of traction and therefore to the situation of the mucogingival junction line, which influences the displacement. So now you are probably wondering if we still need extraction. At first, we have to assess the posterior discrepancy. We have to check the posterior alveolar space, the residual posterior growth, and the facial depth. Then it's important to observe the evolution stage of the wisdom teeth germs. If it's a coronary germ, you can conserve it. But if the roots have begun their edification, you must extract them. To illustrate these ideas, we will continue with Adrien. Adrien was 11 at the beginning. It's a 2-step treatment. He was also in class 2 and has supraocclusion. The X-rays show skeletal class 2 by mandibular retinosism. He is hypodivergent. He has alveolar compensation and supraocclusion. So we are treating him with class 2 activator in step 1. He had the monitoring growth step and an eruption incident has occurred with his 35, and we decide to pull it. He is now in skeletal class 1, hypodivergent with mandibular proconation and a maxillar retroclination. After leveling, we are near an occlusal class 1 with maxillary spaces, and we have taken X-rays at this step. The X-rays show a sagittal expansion of the arch, and the inferior incisor is bordered to the labial cortices. We decide to recenter it by a total arch retraction on posterior meniscus with short hooks placed mesial cuspids to maximize the repositioning. We should have reborn the right bite blocks, but he has no discomfort. He was wearing class 2 elastics during all the mandibular retraction. Finally, we have obtained the appropriate incisor repositioning without any extraction, but he had a good facial depth and posterior growth, and these were very favorable conditions. So I think it's a big difference. Let's look at another cases with Tom. Tom has an occlusal class 1 relationship, probably due to alveolar compensation. And the X-rays are showing a skeletal class 2 by mandibular retonacism with alveolar compensations. The mandibular incisor is procline. In this case, we need to unlock the mandibular growth by the alveolar decompensation. Then we apply the same schema with mandibular arch retraction. I think the screws have been inserted between 6 and 7. And in the retraction is associated with class 2 elastics. So we have obtained an important repositioning of the inferior incisor. And if you look at the with dentists, you will see that their situation has not worsened. So we have to talk about another aspect. We will see with Jules that we need to sometimes move the meniscus from the lower to the upper arch, and vice versa. So we relocate the meniscus. On the intraoral views, we see an occlusal class 2 with a biproconation and a tooth discrepancy between the central and the lateral upper incisors. The laterals are very thin, and this is increasing the occlusal class 2. He has a class 2 division 1 by mandibular retonatism with a biproconation in the context of low vertical growth pattern. Moreover, he has a molar dysymmetry and a slight canted occlusal plane. You can see there. But first, we have line and leveled under the control of the screws. Thus, we have retracted the inferior arch for incisor centering. The skeletal class 2 has been corrected by the poroscope, and then we placed the class 2 elastics for stabilization. The meniscus have been relocated to the upper arch for the correction of the occlusal plane tilt. On this slide, we can observe the evolution of lateral X-rays at the 3 treatment steps beginning, mandibular protection after arch retraction, and at the end, correction of the occlusal plane tilt. The supine position shows good mandibular growth response with an anterior center of rotation. You can see there's a rotation around this point. And a better alveolar 8 equilibrium. The lower incisor repositioning is about 17 degrees without stripping and only with the teeth extraction. The treatment is performed with good occlusal class 1, and finally, we also have a nice smile with a good exposition of the upper teeth. Here is mine. Sorry, my cat is dreaming. Perhaps you can hear it. Now we know everything about the first situation, and we can start with the situation 2 concerning dolichofacial patients. Here we are faced with hypodivergent patients, and what can we expect from this? In this configuration, we are expecting a mandibular condylovice rotation to optimize the growth by vertical closure of the compass, and we can mix maxillary retraction and mandibular protection. As we have seen at the beginning, our choice will also depend on the strength of the mandibular elevator muscles and their capacity to counteract the compensatory molar extrusion. Also, in this situation, we must make best use of existing growth potential. The worse the growth direction is, the higher the necessity is for us to control both anteriorly and posteriorly. Our aim is to obtain a vertical closure by counterclockwise mandibular rotation. So the center of rotation in this case is posterior. Thus, according to the smile line, we can combine upper mini screws and class 3 elastics. The lower arch will do a counterclockwise rotation with an extrusion of the incisors, or we can opt for a schema with 4 mini screws in order to increase the vertical control of the lower part of the face and the smile position. Corentin is a good case to illustrate this situation. We love these boys who are younger looking. Despite his age, he has a lot of residual growth and it's good prognosis. The intraoral views showed the maxillar crowding and the full molar class 2 associated with a transverse deficiency. The X-rays are confirming our clinical conclusions. He had a skeletal class 2 biomandibular retinoscism and vertical growth pattern tendency. The lower incisors are buccal. So to summarize, he has skeletal class 2 mandibular retinoscism. He is hypodivergent and has alveolar compensations and crowding. We have anchored the upper and the lower arch. We have distalized the upper molar for alignment aids, as well as in the lower arch. The mandibular anchorage counteracts the protector size effect. At the end of the protection, the class 2 elastic takes the place of the fosses. And here are the outcome with a good class 1 relationship. The X-rays of revaluation on the superimposition are showing a good vertical control of the posterior areas, allowing the counterclockwise rotation of the mandibule and the optimization of the condylar growth. The lower incisors are anteroposteriorly and vertically controlled, and that's also a key to optimize the mandibular response. So Corentin has grown, his face has changed a lot, and he has a beautiful smile. But we should consider what we would do with incisors in the case of growth failure. Here is the case of Océane. She was a transferred case. She has been treated with conventional techniques without any results. Our mother asked me to treat her with fixed appliances and no cooperation issues. As you can see, she has a full class 2 molar relationship. So she has 15, and we have an unfavorable growth prognosis. The process has been supported by a hook anchored with the meniscus in order to avoid the pronation of the incisors. We have obtained the occlusal class 1, and it's still stable after 2.5 years. But we might be worried about the incisor situation because we have slide all the arch, and there is a little labial bone. The cortical bone is very thin. So, to avoid the bone thinning due to the vestibular version and decentering of the mandibular incisor, you can reduce the protection duration. In order to do this, a combination of maxillary retraction and mandibular protection with good vertical control is a good solution for a full class 2 relationship. Another way is to reduce the wire to a round section on its anterior part and anchor it to the meniscus. You will avoid the forward movement of the crown, and you will obtain a backward movement of the apex. It's the expression of the momentum. When you have a backward movement of the apex, you have less periodontal risk. In this case of class 2 division 2, in a context of biretronatism, the growth wasn't good enough, and we have accepted alveolar compensation. But I didn't want to take a risk for the roots. So I have reduced the wire in a round section regarding the incisors to allow a controlled version. The aim is to move back the apex. You can see it now on the last X-rays and the superimpositions. So, in conclusion now, and to summarize the main ideas of this presentation, we know now that the control of the mandibular incisor is a prerequisite indispensable to the mandibular response to our class 2 mechanics. It's an absolute goal in order to respect the periodontium. Part of the occlusal pain control is a condition to functional response and aesthetic enhancing. Sagittal expansion and mesial leeway of the arch are obstacles to mandibular growth and do not ensure stable correction of facial aesthetics and smile attractiveness enhancing. Keeping alveolar compensation is like putting the brakes onto the mandibular growth. As we come to the end of my presentation now, I would like to thank you for your interest and attention, and I would like to take this message home with you sometime. It's good to go back to the classics. Our old masters always told us to control the mandibular incisors to have the best results. They had a perfect understanding of the growth process, rotation, and typology, but they had a lack of tools. Nowadays, with TADS, we have tools, and we must make best use of them to optimize the existing levels. Thank you.
Okay, thank you very much. I finished your webinar? Yeah, it was a great webinar. Thank you for your effort to share your knowledge with the world despite of the bad condition. Yeah, Dr. Caroline. And we apologize to all attendees for the inconvenience caused by technical problems through the webinar, but the webinar is so too good, so it's okay. And now we have a time for question and answer. I believe the panelists have questions in regard to the lecture. Meanwhile, I'll try to get some questions from the chat box. Okay, Dr. Kim and Dr. Chow. Okay.
It was very impressive and interesting topic. I have one question. There are class 2 divergent cases which are using orthodontic ministry. When using,
Dr. Zhang, can you speak more loudly?
okay, when using a screw, there may be a problem that intrusion of the
I'm sorry, but I can hear you.
If Dr. Chang send me your question, then I'll ask the question for you.
Yeah.
Okay. Okay. The Dr. Chang asked, there were class 2 hypodivergent cases which were using orthodontic mini screws. When
Yeah.
using the mini screws, there may be a problem that the intrusion of the dentition might worsen the vertical problem of the patient. In other words, or hypodivergent facial pattern. If there are any precautions in this regard, please let us know.
Oh, I think when you have an hypodivergent patient, you should look at the equilibrium between the alveolar posterior height in the maxilla and in the mandible. And if the posterior alveolar height is higher in the mandible, you should insert the screws in the mandible. And you will see that you will get better equilibrium. It's a question of Enloe schema. It's a very classic rules, you know. And sometimes you can also compensate by a tip forward in your Y on the posterior part of the Y. And it's a good solution with also vertical elastics.
Thank you. Doctor, I also have a question. I was very impressed with your delicacy of paying attention to the problems of mandibular incisors in the class 2 orthodontic treatment. And I was able to learn a lot. Thank you for the great lecture. I have a question. In the class 2 cases, you installed the mini screws in the upper jaw and used class 3 elastics for correcting mandibular incisor inclination. If class 2 corrector are used again after that, I wonder if there is any burden or a side effect due to the round trip movement of the mandibular incisors. I wonder if there are any specific measures to prevent any side effect. Please let me know.
Okay. I think we need to anticipate the centering, and if you have a good centering after your preparation of so before your class 2 biomechanics, if the incisor is well centering, and if you encode it to the screws before the use of the class 2 elastics or the protection with the faucets or whatever you used as a protector, perhaps you will have a slight proclination because of the strength of these forces, but you will get less proclination at the end than if you don't prepare your case with a good centering at the beginning. But it's also depending on the duration of the protection. The more you protract the mandible, and the more you take the risk of the proclination.
Thank you. Would it be helpful if I install a meniscus in the posterior side of the mandible and make an indirect anchor to hold the anterior incisors? For say, if I make anchor in the posterior side, posterior of the mandible, and make a ligature to hold the canine, or would that be helpful to prevent any side effect of round trip
yes,
of the
of course.
Yeah. Thank you very much.
Thank you.
Yeah, thank you very much, panelists. I have some question with me, and from the chat box of Zoom and from the YouTube channel. Kindly answer shortly to the question in order. If you have no idea or can't understand about question, you can just leave it. We have only 4 questions.
That's okay. So, which appliance I prefer? You know, I'm speaker from American Orthodontics, and of course, I'm using their power scope, and it's a very good protractor because its direction is parallel to the occlusal plane. So I like this protractor, and you can activate it in completely asymmetrically. You just have to put different crimpable shims on the sides where you have some interest. But I have used a lot of different protractor, the forces for a long time, and the Liberty Biel. It's the dealer is RMO. I don't know if you have this one, but no, I think the power scope is definitely the best. The lingual re-education. So we have, I don't know what is the word for this. We have clinicians who know how to do re-education with the tongue. So it's a problem with patients with open bites. You need to close the plants, but sometimes the tongue is going towards the teeth, and you can obtain the correction of the overbite. In subdivision cases, okay, and in subdivision cases, the hooks are always fixed. It's difficult to explain all the techniques in one webinar, but we are used to fix the hooks. But I have another biomechanic schema with 2 coils, one on the arch to distalize 1 molar, and another between the anterior hook and the meniscus to distalize all the anterior teeth. So we we have to adapt our biomechanics with the case. How to round tipping when the... What do you mean with round tipping? To avoid round tipping.
Yeah.
Yeah, I think it's the same question that I asked you before. I think
Yeah.
round tripping of the lower mandibular inclination. So yeah.
Okay.
Can you see the last question?
Yes, yes. So for the hyperdivergent patients, we have always a vertical control by an elastic chain between the Y and the screw. You must be aware about one thing. You need to apply torque. It's coronal-lingual torque to avoid the side effects of the intrusion. And usually, I think I put 10 or 15 degrees torque. I apply, yes, I think it's about 10 and 15 degrees torque in the Y.
Okay. Thanks for answering the question kindly and patiently. That was all question I prepared today. I think your lecture today is so perfect that the audience doesn't have many questions in your webinar. That was really great and meaningful time for us to learn about your great knowledge. Now we will wrap up the webinar.
It was my first time in English, and I'm not used to do this. So if it's clear, I'm completely happy with this.
You did great webinar. You did it. Yeah.
Thank you.
Now we will wrap up the webinar if there are no further questions. And thank you everyone for your support. And WEBCEPH X have prepared something as a sign of gratitude. It is a certificate of appreciation. We are really impressed by your effort to share your value of knowledge with the world and your first time your webinar in English to the all around the world attendees. Well, Dr. Caroline, do you have something to say to the attendees before ending?
Thank you. Thank you for your interest and attention. And that was a great pleasure. Thank you to everyone. And have a good day or good evening. And hope to see you soon. Bye-bye.
Yeah. Today we have 160 attendees attending this webinar through YouTube channel and through the Zoom, and it was really great. Now we will end today's webinar at this point. It was a meaningful time for me and the members. Thank you everyone for attending today, and special thanks to Dr. Caroline, our speaker. Hope everyone stays safe and healthy until we meet in our next webinar. Thank you very much. Thank you.
Thank you.
Thank you very much.